Thank you very much. Hi again, everybody. The first report of electric therapies were from the ancient Greek and Romans that use electric fish like eels or torpedo for the treatment of arthritis, for example. And the first proctological use of this kind of treatment was for an external rectal prolapse in which they try to electrificate the mucosa with the fish, trying to reduce the prolapse. We don't know how we... But about fecal incontinence is a very huge problem. We know that is common in general population, but most of all in geriatric or neuropsychiatric ward. So maybe they are not the good candidates for third-level treatments. But in Italy, at the moment, there are about 2 million people suffering from fecal incontinence. And is a very common problem after obstetric trauma. We are lucky because just about 30% of patients come to us for a consultation, so it's okay. There's a lot of interest about sacral neuromodulation. In the years, the rate of published paper about it is increasing, and every year about 30-40 papers about sacral neuromodulation for fecal incontinence are published with very good results. And these results are confirmed during the time. So it's a good news. Guidelines, as we see, consider sacral neuromodulation as with a strong recommendation for fecal incontinence. And Cochrane do it, American guidelines do it, French guidelines put it here, International Continence Society put sacral neuromodulation almost everywhere. So, yes. But what are the good indications for sacral neuromodulation? Because at the beginning, we thought that the integrity of the anal sphincter was a prerequisite of, for the success. So no damage. How could a damaged sphincter works better with sacral neuromodulation? We don't know, but we saw that they do it. So, but how big should be this defect to benefit from sacral neuromodulation? And we try 33, we try 60, 90, 120, 180, total missing of the sphincter, and sacral neuromodulation still seems to work. And so why this? We don't know. But something we have to see, so that now talk about degrees for damaged sphincter have no more sense, because the sphincteric complex is a three-dimensional functional structure. So we can say 120 degree with no continence problem, and we can say that we have a patient with just a 40 degree, but for all the anal canal long, that have really bad outcomes. So now we have to talk about something like this score, that is the Stark score, that quantify the defect. No more bidimensional view, but three-dimensional. Well, if we have a sphincter defect, we can treat it with sphincteroplasty. But if we compare sacral neuromodulation with sphincteroplasty, we see that sacral neuromodulation seems to win. But why this? Because we absolutely don't know what kind of sphincteroplasty and in what kind of patient they do it. Because, for example, everybody of us know that if we do a sphincteroplasty just after the trauma or just after the injury, it goes very well. But if we do a sphincteroplasty in a patient after 30 years from the obstetric trauma, maybe the outcome will not be so good. But what we know, if, for example, in the United States, the diagnosis of fecal incontinence are increasing, the treatment with sacral neuromodulation are increasing, but the number of sphincteroplasty are still the same. And surgeon that starts to approach to fecal incontinence prefer to start with sacral neuromodulation rather than sphincteroplasty. And if we see literature, we see that there is interest about sacral neuromodulation, but very few papers about sphincteroplasty. Less than 10 per year. So if you have to choose something to publish, I suggest you to choose sacral neuromodulation. Also because in the long term, results are confirmed. But we know that, for example, it's not the same for sphincteroplasty, that after 5 years, about 50% of the results are fallen. Of course, sacral neuromodulation has shown positive results also for fecal incontinence, for example, after treatment of rectal prolapse, or fecal incontinence associated to defecation problem. And also after rectal resection for the treatment of fecal incontinence associated to LARS. This is the reason why sacral neuromodulation have been included also in the treatment algorithm for low anterior resection syndrome. And that's all. So it is something like sacral neuromodulation always win, but is not the true. The true is sacral neuromodulation is maybe for the first time a functional treatment for a functional problem and not an anatomical treatment for a functional problem. And is more like rehabilitation than sphincteroplasty. So maybe we have to compare sacral neuromodulation not with sphincteroplasty, but with rehabilitation, because that is the field of action. Thank you very much.